Welcome to the Gifford Provider Podcast, the podcast of Gifford Healthcare based in Randolph, Vermont. I'm Scott Fleischman. Gifford is a nonprofit critical access hospital and federally qualified health center with a total of 9 locations throughout central Vermont and the Upper Valley. Gifford's main campus in Randolph is home to a 24-hour emergency department, inpatient and rehabilitation units, a renowned birthing center, an accredited cancer program, advanced diagnostic imaging, surgery, and much more. Go to giffordhealthcare.org to find all the services we provide, the latest news, blogs, and healthcare information. Our guest this month is General Surgeon Dr. Dawn Holman. Dr. Holman joined Gifford several months ago along with her husband, Dr. Alexander Sokolovsky, also a general surgeon. Dr. Holman today is going to talk about her experience in breast surgery. October is Breast Cancer Awareness Month, so there's a lot of information we're going to be getting into. But before we get into that conversation, if you're watching us on YouTube, don't forget to click the subscribe button, like this video, and tap the notification bell. That way you'll always know when we have new content for you to watch. On our YouTube page, we have other podcasts, important information from our medical team, and testimonials from patients and employees. You can also listen to the Gifford Provider Podcast in your car or while going for a walk. We are on Spotify, Google, Amazon, and Apple Podcasts. Just do a search for the Gifford Provider Podcast. Follow the podcast and share it with your friends. Leave a comment and review. That will help us out a great deal and help this podcast spread throughout the community. So again, Dr. Holman, thank you again for being here today. Very important topic.
Yes.
October being Breast Cancer Awareness Month. We had your husband here last month to talk about colorectal cancer and colonoscopies and kind of the myths surrounding that. Unlike lung cancer, where you don't really know you have it until you have it, colorectal cancer, breast cancer, those are cancers that you can detect with preventative care.
Correct.
And that's why it's so important to talk about this and get people to act, and because they could save themselves.
Exactly. Right. It's a very common cancer. Actually, as I'm sure you probably know, in Vermont in 2019, there were 139 cases for every 100,000 women. So overall, there were 609 breast cancers diagnosed with a resultant 79 deaths. In comparison, in the U.S., it's very similar. It's about 130 per 100,000 and a similar death rate. In Vermont, it's actually the most common female cancer overall. It actually surpasses the amount of lung cancer, almost double the amount of lung cancer diagnosed in women. And it's the second most cause of death in women due to cancer. Once again, lung kind of beating out on that edge. But it is a very common but cancer that we can treat very well these days if it's found early. The main risk for breast cancer is being a woman and being an older woman. Breast cancer increases as a woman ages. The next most factor is just the overall estrogen exposure, which is one reason why women as they get older are at higher risk for breast cancer. Certain lifestyle factors in terms of, when you have your first child, women who have older first pregnancies, women who never have children are at higher risk because of that unopposed estrogen exposure. Factors that women don't have a control over in terms of having an early menses and a late menopause, once again, have longer exposure of estrogen and therefore at higher risk overall.
How about family history?
Family history, that's a very good question. 20 to 30% of patients with breast cancer will have a relative with breast cancer, but only 5 to 10% of women with breast cancer will actually have a breast cancer genetic mutation. So the idea that it has to be genetically related is not true. 1 in 8 women, or 12% of all women across the country, are going to get breast cancer at some time in their life. And when you look at the amount of female relatives you're going to have in a family, then obviously, there's going to be women who are in the family with breast cancer, but it doesn't have to be a specific gene that is causing the cancer.
Some of those stats are just scary.
Yes.
I mean, have we seen an increase in it over the decades? And if so, is there a reason?
The main reason is that the population is aging in general. More people are living longer than they used to many years ago. We're also seeing more because we are able to diagnose it earlier than we used to. It used to be women came in with the lumps that they could feel at already advanced stages. So women who nowadays we would find early by just something as simple as a mammogram, we weren't necessarily finding at all, or the patients weren't reporting anything to their doctors. Unfortunately, there is still a percentage of the population who just doesn't want to deal with it and wait until it's really quite late in the process.
I guess technology and the way that we've been able to detect earlier has made those numbers what they are today, is because we're able to
find more cancers than we used to.
So,
and then there's also the simple things of, reporting processes and all of that have changed. But the main thing is that there are more women in the country, there are more older women in the country, and we're finding more cancers overall than we used to.
the mammography process probably is a little bit better too than
Absolutely.
in years past. The technology has
Yes.
helped that better, so it's not
Yes.
as a painful as a procedure as
Exactly.
years past.
Any woman who's had to undergo a mammography knows the basics of that. Basically, look at the breast in kind of two views. There is now new mammography technology, what some people will call 3D mammograms, where it takes more pictures at sort of an interval of angles to create more of a 3D reconstruction of the breast. And that has the advantage of being able to look at the breast more as a whole, as opposed to just a static image of the breast. The issue is that women, particularly younger women, they have very dense, very heavy breast tissue, and it is really easy for there to be overlap of that tissue and difficult to see what may be real, what may not be real, or to look at something. Women, as they age, have more fatty breasts, so a mammogram's a lot easier to read. So now that we have this better form of a mammogram, we're able to find things, once again, a lot easier, a lot sooner than even 20 years ago with just, the regular standard mammogram.
I would hope that the younger generation be more proactive, just seeing what the generations ahead of them have had to go through.
Right.
And now, hopefully, with this information, knowing that it's not as a painful of a process, or it's not as, it doesn't invade. It's not as an invasive process.
Right. They're able to do things a little bit easier and get much more information. And this is a question that's come into a lot of debate and controversy, is when to start the mammograms. That has been through the news and all of that. And there's a very interesting backstory to why the recommendations used to be the way that they were. It used to be that the data was from way back where they didn't really include younger women and didn't include older women, meaning greater than the age of 75. So they had a very small cohort of women that they looked at whether or not the mammogram was a benefit. So the recommendation used to be to start at age 45 or 50 every other year up until age 75. We now realize that doesn't make any sense, because women of all ages get breast cancer.
Sure.
And in particularly, once again, as you age, you are more likely to have breast cancer. So multiple societies, including the American Society of Breast Surgeons, which I'm a member of, as well as the American College of Radiology, all of that, they have come up with the idea that every woman between 40 and 45 should at least, at a minimum, have the conversation with her doctor about getting a mammogram, to get annual mammograms, certainly from ages 45 and up, and to not have a magic stopping age of when to stop having mammograms, but rather to look at the utility of the mammogram. So if the woman has a more than 10-year life expectancy, to continue to do them. So a woman in her 80s who's in great health should continue to get mammograms. So A lot of societies have said this is what to do. American Cancer Society and the U.S. Preventative Task Force are still going to more of that older model because they're using the older data for it.
What, is there a reason for that?
There is a reason for that in terms of they looked at two models. They looked at the efficiency model and they looked at the life saved model. And even though there is a mortality reduction of 15% by having earlier and more consistent mammograms, they chose to go with the efficiency model.
Interesting.
Yeah.
You see that changing?
I think it's slowly changing as more of these societies are pushing for it, but it's going to be a slow process. And the main thing is for women to continue to advocate for their own health care. And it's actually a recommendation that starting at age 25, women have the conversation with their primary care about their specific risk factors and then start to assess for, are they at average risk, are they at higher risk, and what sort of screening and the timing for it.
So I'd be remiss to say that obviously here at Gifford we do mammographies. You perform stereotactic breast biopsies.
Correct.
So tell me what that is.
Well, basically in the old days, being 20, 25 years ago, it used to be if a woman had a mammographic abnormality, something that we couldn't feel, we would have to what we call wire localize or place a guide wire to the area to then guide a surgeon such as myself to perform an actual invasive excision of the area just to get a diagnosis. Now with the stereotactic biopsy, we're able to take the two views and then kind of do the 15 plus and 15 minus, like the old stereoscopic things that you'll see in museums, and have the actual coordinates in 3D calculated to where that abnormality is. Able to use the mammogram machine, make a very tiny incision on the breast after numbing it, and insert a special biopsy gun that takes out small pieces of tissue to provide a diagnosis. So a lot less invasive for the woman, minimal discomfort since it's the local anesthesia, and provides the answer so that if it is to be nothing, we've saved the woman in a big invasive surgery. And if it's something, we can then appropriately deal with it.
Rare for a small rural hospital such as Gifford to have this?
It is. We're very fortunate to have that here. It is the sort of thing that the big tertiary care facilities will use as a selling point for coming there. But fortunately, we have one, and so women don't have to make that long trip to just get something as simple as a 15, 20-minute biopsy.
Have you seen an uptick, an increase in women taking control and getting the procedures done?
Absolutely. It particularly happens in October and November as people kind of remember that they're supposed to get their mammograms. Our radiology department is very good about sending out reminders for women. So if they haven't had their mammogram in a year, they're getting reminded that it's time to do that again, because once again, the best thing is to find something early where it is incredibly treatable. And women who have what's called localized disease, meaning it's only in the breasts themselves, have a 98% 5-year survival rate. So finding it early is obviously a huge thing.
You're a general surgeon, but breast care or breast surgery is really your specialty. That's
correct.
So yes. Tell me where that came from for you, because there's plenty of procedures that you do, but why the focus on breast surgery? Why is that kind of mean more for you?
I think because it is the sort of thing that can be easily overlooked. A lot of women just don't want to think about their breast in general. Quite honestly, a lot of women don't want to see a male physician to provide that sort of care. And being able to utilize these techniques where you're able to see the woman right from the very beginning with the biopsy all the way through the course of her care. That's very satisfying in terms of being able to help and support somebody through the whole process. And I've been fortunate enough to be able to expand my skills over the years to include these minimally invasive biopsies, use some special operative techniques for helping to keep the breast in as good a form and minimize any disfigurement from a breast cancer surgery.
And I think that, we've talked before. I think that's what you love, is the fact that you can be with that patient from that very opening stage of that initial mammogram and kind of see the care all the way through. How important is that for you?
It's very important. I mean, a lot of surgery, you do know the patient, you go and you fix the problem and you see that they've done well, and that's what you were there to provide the care for. With the breast patients, it is more of almost a lifelong process, because you've been there for the biopsy, you've been there for the surgery, you've been there for the aftercare, and then you continue to support with the yearly, we need to do your mammogram, we need to do your exam, we need to keep on top of things for you. So it really becomes a good lifelong relationship with the patient, which is something that you don't get in a lot of surgeries.
Let's talk about mastectomies.
Yes.
That is something that you do, obviously, as well. And you've had an extensive background in it.
Yes. Fortunately, mastectomies themselves, we need to do less these days, which is the side effect of having the earlier detection. Mastectomies these days have much more limited indications, which is a good thing. First and foremost, if that's the woman's choice, because ultimately the woman is in charge of her own body. And given that it's breast, everyone has a different view and psychological approach to their body for what's going to make them the most comfortable in their own body. So it's always a woman's choice for the mastectomy if that's what she wants. If the cancer is such that we can't physically get it out of the breast, so a large cancer in a small breast, then a mastectomy becomes a choice. And there are some cases where a woman wants what's called a prophylactic mastectomy, where they have a higher risk of breast cancer and they just don't want to go through the continued screening, and they would just rather have the breast removed. So there's some indications for it. Whatever the indication, I've had plenty of experience with it. So it is a surgery that is done, but fortunately done less frequently based on need.
Psychologically, is it tough for women to have to go through that?
Oh, absolutely. I mean, there is a lot in this culture, obviously associated with breast. I mean, you just look at advertisements and media and all of that. So there's a lot associated with it. So each woman does struggle for what the right decision is regarding the breast. And that's where trying to provide that emotional support and trying to provide some of the statistics and the history and the risk and benefit and all of that, so each woman can come up with the best decision for them.
Let's talk a little bit more about your background in general surgery.
Well, I did my residency in general surgery back in Chicago, and it was a very busy thing. We were associated with a lot of trauma, multiple major metropolitan hospitals there. And that serves its purpose, no question about it. It gave me a great range of experience with things, but it didn't provide me that connection with patients. And so I very quickly learned that's not what I want to do. I want to be in a community where I feel like I'm part of the community, where I know the patients, they know me. We're going to see each other at the grocery store. They're going to feel comfortable with me, and that good relationship. And so that's what, I was looking for, and I didn't have any desire to be in a big city in a big tertiary care facility with sort of that, this is number so-and-so of the day, as opposed to this is Jane that we're going to be taking care of.
And that's what I hear a lot of, is people who come to Gifford to be provider, they like that aspect of it, being able to care for the people that you see every day.
Right. Yeah. Yeah. And that was one of our main reasons to come here, was just the overall atmosphere from everybody, from the people at the registration desk all the way through up to administration, how focused they are on helping the community.
How is it like working with our radiology team? We have Jennifer Hubert, who we had on last year, right around this time. She's the breast patient care navigator who we spoke with last year. Great interview. It's also on our YouTube page if you want to check that out. A lot of great information there as well. What's it been like working with that team?
Oh, the team here is phenomenal. The mammogram technicians, the ultrasound technicians, they all not only have wonderful skills, but they are so good with the patients. And then it is unbelievable that Gifford has such a wonderful breast care program. And this is virtually unheard of for such a smaller facility to have someone like a breast care navigator. Jennifer starts out with them with their mammogram and ultrasound, and when they need a biopsy, she is right there to help explain the whole process, get the patient hooked up with me so we can get it taken care of. She follows through on everything. She provides so much emotional support. I mean, honestly, I have never seen a hospital of this size have that degree of breast care before. That's normally something you have to go to a bigger place like Dartmouth in order to get. So we're very fortunate that we have that here.
Starting to wrap up a little bit here, what are some of the myths out there? Getting a mammogram or a biopsy, how the procedure is done, the pain.
Well, I think the first thing is the pain, like you said. Mammograms are not as painful as they used to be. It's not those big heavy lead plates, that sort of thing. As the biopsies are less invasive, obviously the pain is a lot different from there. Doing a biopsy does not spread the cancer. The biopsy helps us diagnose to be able to plan the appropriate treatment. Back when it used to be you had to do the excisional biopsy just to get the diagnosis, then now you've diagnosed breast cancer. Now you're having to go back and do definitive surgery to make sure you have all of the cancer, to check the lymph nodes. Now that we can do the minimally invasive biopsy, we can get the diagnosis and perform whatever the appropriate definitive surgery is at one time, as opposed to multiple different invasive surgeries.
In your work, is there any positive stories you can share how this preventative care really stop something bad from happening?
Well, there's a lot of stories, but one in particular comes to mind, a woman who had tried to avoid her mammograms, but, did ultimately follow the rules, even though had always argued against following the rules, went and had the mammogram, found a small area, not big enough for her or her physician to appreciate, had the biopsy done, found that it was a aggressive tumor, was able to get a surgery done and then undergo chemotherapy and radiation treatment, and then still be around 10 years later. If she had given in to her will to not get the mammogram as opposed to listening to everybody, it would have very easily been a different story a few years later.
Can we talk a little bit about precancerous
Right.
and what, how that's discovered and the treatment for that?
Right. Precancerous is pretty much always discovered on a mammogram, sometimes on ultrasound, but typically on a mammogram. It's usually associated with microcalcification, sometimes with just a little weird asymmetrical area on the mammogram. Once again, we find it with a minimally invasive biopsy. Since it is precancerous, it's a much easier, simpler treatment. You do have to excise the entire area to, first of all, make sure you have all of those precancerous cells gone, and then also to prove that there isn't any invasive component that was not seen on the initial biopsy, and then to treat a woman with radiation afterwards as a preventative measure for getting cancer in the future.
Now, does that woman now have to get her mammograms more rapidly or can she, wait just the same length of time, or because she has had precancerous cells there, now she has to be in?
It is definitely still a mammogram every year. That is the bottom line that every woman should take away from this discussion today, is that you need your mammogram every year from age 40 until much later in life based on how you're doing. No set cutoff date. In addition, there's other screening tools that are used based on a woman's individual circumstance in terms of aggressiveness of a particular cancer or precancer, family history, that sort of thing. And one of them is to use alternating MRIs and mammograms. And there are indications and protocols for using that sort of setup.
What are the odds that if you catch something precancerous that it will return, even with the radiation treatments? I mean, is there
It's less. It's more likely than the average woman getting cancer to begin with, because obviously you've had precancer, but it is still not common. So that's another reason that the mammograms are so good, so that we can find things, before they even develop into that next step and help prevent a cancer in the future.
Well, like you said, if there's one thing to take away from today, it's once a year from 40 on.
Yes.
Get your mammogram. We provide them here at Gifford. There's no long wait. You can schedule your appointment. You can come in. Regardless of family history, size of the breast, anyone can get breast cancer. You need to schedule your yearly screening mammogram. You can do it at Gifford. Contact our radiology department, 802-728-2214. Our breast care navigator, Jennifer Hubert, you can contact her at 802-728-2231 with any questions or concerns about the mammography process. And you can go to our website, giffordhealthcare.org. And again, the Gifford Provider Podcast is available on YouTube. If you want to watch it, you can also find us on Amazon, Apple, Google, and Spotify as well. Just do a search. And Dr. Holman, thanks again.
Thank you very much.
We'll see you next time on the Gifford Provider Podcast.